My name's Haddy. I am an emergency physician. I was born and raised in the wonderful sunny Worthing, but have lived in Brisbane, Australia, Brisbane and Sydney for the last 20 years. And I practice on Gadigal land, which is Sydney. I have an interest in gender and racial equity and enhancing the outcomes of chronic pelvic pain patients in the ED. And I'm also part of the New South Wales community of practice for FGMC, also part of the Australian Health Practitioners Network Support Service, which my wonderful friend Mari, who is with us tonight, is also a part of. And so, yes, that is me. So thank you for having me. I'm going to be talking to you about beyond anatomy, so improving gynecological care for patients affected by FGMC. This topic is an important but often confronting one, as Steph has said, and it's female genital mutilation / cutting. We'll explore its cultural roots, the physical and psychological trauma it causes, and most importantly, what healthcare professionals and patients can do to support affected women and children and advocate for themselves during the gynecological exam. So as we've just said, in terms of psychological safety, before we begin, I'd like to acknowledge that this topic involves sexual trauma and violence. If at any point you feel uncomfortable, please feel free to log out and take care. So some learning objectives: to understand how to provide compassionate care. We first need to understand why this practice happens. FGMC is not just a medical issue, it's a cultural practice passed down through generations in certain communities. I will be using the terms women and female because the overwhelming majority of people who are affected by this do identify as that. But I will acknowledge that there are people that don't. That's kind of just the WHO terminology. We'll speak about what it is, why it matters, how it can shape gynecological procedures and care, how you can advocate for yourself, and what clinicians can do to make things better. Highlight where evidence is lacking and where you can go for further support and resources. And I've got a couple of links, actually. I'll just pop them in the chat at the end. So what is female genital mutilation or cutting? So this involves the partial or total removal or injury to the external female genitalia for no medical benefit. There are about 230 million women and children globally who are affected. The number is probably more. And as we've said, close to 140,000 of those reside within the UK. It's not a rare phenomenon. It's present within our communities, within our hospitals, within our waiting rooms, within our circles. It's a practice that's deeply rooted in tradition. And as I've said, it serves no medical benefit. The WHO wants us to recognise that this is a form of gender-based violence and is a human rights violation. And I've just put this table in to show you the prevalence of FGMC in certain countries. So you might see through West Africa and the Horn of Africa. And I guess part of the reason why I'm interested in this is because I am of Gambian heritage. And you can see the number is quite high. So it is a practice that is very strongly linked to the culture and from which I come. But it is not just, in clinical care, it's not just a definition, it's anatomy altered, it's pain remembered, and it's trust negotiated. Some of the global challenges. So it's been a rite of passage into womanhood for centuries. It's associated with purity, modesty, and even marriageability. And it's a practice intricately woven into more than 30 countries in Africa, the Middle East, and Asia. And some countries, that you might not necessarily expect. Places like Indonesia have a very high prevalence, which is relevant for us down in Australia. And also some countries, anecdotally, that you might not expect, such as places like Colombia, Russia, Yemen. Migration has a positive influence on abandonment of this practice, because the studies show that relocating to a country such as the United Kingdom or Australia, where FGMC is not the norm, can lead to its abandonment. When societal expectations shift and when women no longer see this as necessary, we can take steps towards breaking the cycle. This does create challenges for healthcare systems like ours, where we often lack culturally sensitive and trauma-informed approaches to care. So the reality is that many healthcare professionals lack the confidence when managing FGMC cases, and training tends to focus on midwives and women's health specialists, which is fine and obviously very appropriate, but there are big gaps, especially when it comes to general practice, emergency physicians, allied health. So certain people in specialties can feel underprepared, and we urgently need broader education across the whole healthcare system, which is why charities such as Tiger and everything that we're doing to promote awareness is really important. You might hear different terms. So FGM is the term that's used in legislation, so female genital mutilation, and with the WHO, and that kind of just shows the, I guess, seriousness of it. But if you ask a woman, she might not see herself as mutilated, and I guess it is kind of stigmatizing language. So terms like cutting or circumcision are often more palatable. There are lots and lots and lots of different words for it within local languages. For example, sooner is one of them. But the recommendation is that you should use the terms that align with the patient's comfort. Ask them what term they prefer to use, stick to it, and respect their choices. And I won't get too far into the classification guide, but just to let you know that there are 4 different types. The first 3 types kind of correspond to what tissue is excised, but I will draw your attention to type 3 because that involves making a covering seal over the vaginal opening or orifice. And so you can kind of imagine some of the issues that might come with that. And type 4 is kind of other harmful procedures. So piercing, cauterization, scraping, pricking, that sometimes happens at birth. So while tradition explains its origin, it doesn't justify the consequences, which can be devastating. Women who undergo FGMC are at risk of severe pain, recurrent infections, menstrual issues, childbirth difficulties, and even death. And just because, in the UK, it's not a traditional country where FGMC occurs, you can still see some of the short-term effects, and that's because there is a phenomenon known as holiday cutting, where families might take the children and go and have it done in their country of origin and then come back. So you might see these short-term effects in girls that have just returned back from this happening. So you need to be aware that it happens, and particularly like after the long school holidays and things like that. That's a common time for it. The psychological scars are just as profound, often lifelong. Women might develop PTSD, anxiety, depression, or engage in self-harm. And these aren't just abstract possibilities, they're everyday realities. And as an emergency physician, I have seen FGMC present with patients that have come in under the Mental Health Act because they're under such extreme distress that they are actively suicidal and wanting to hurt themselves. There are cases where children have witnessed their own siblings FGMC and attempted to harm themselves in very graphic ways just to avoid doing it. And so the mental health impact of this really cannot be overstated. And what have we got here? Yes, and sexual health. So the impact of sexual function depends on the type and the severity performed. So some women might not have much change with their sexual function. Some might have a significant amount of change. Women often experience reduced lubrication, scarring, nerve damage. This can cause pain during sex, so dyspareunia, and as well as the psychological impact, which we've just had a chat about. And that conditioned pain response can further prevent women from engaging in intimacy in a natural and enjoyable way. Many survivors often feel disconnected from their own bodies, associating sex with discomfort, obligation, or even fear. And just to say that as a physician, medicalizing FGMC doesn't make it safer. Some women might have their circumcisions done, in a village, in a hut by a traditional cutter. Some might have it done in the operating room in the hospital, but you're still removing healthy tissues. So, while sometimes that infection risk and things might not be there, you're still interfering with the natural function of the women and girls' bodies, and it's still gender-based violence. So with all that said, Imagine your standard gynecological exam. So we know about the positioning, think about the speculum, that little click click sound that you always hear us do, the exposure, the time pressure. You might even have an audience if you're in a teaching hospital. And now if you layer in FGMC, and as we've said, depending on the type, you might have scar tissue, narrowing, infibulation, altered landmarks, and that pain with touch or penetration. The WHO highlights that procedures such as cervical screening, IUD insertion, or even just a routine exam can be technically difficult, if not impossible, to perform. But the anatomy is just half the story. The exam is not just physical. For some patients, this exam, even just the opening up of the legs, can feel like a replay. And when I've heard women speak about this procedure happening to them, that feeling of the resisting the when it happens, it just seems to be so triggering and so terrifying. So I can only imagine that the gynecological exam could really evoke that same adrenaline rush and that same fear. So some factors impacting the gynecological exam. So it is often performed in childhood, kind of before that preteen time. Some people might not remember it, but it is done without consent usually. So when a patient is asked to undress, lie back, allow examination, as I've said, it can trigger fear, loss of control, and disassociation. And as we've said, the mental health effects, as I've discussed, can really be triggered during this procedure. So what you might think is someone being non-compliant or difficult is actually probably just them in fight or flight mode and trying to protect themselves. So I'll take some time to just discuss what we can do to empower the patient. The patient is not a passive entity in this story. So advocacy might look like asking for a female clinician, requesting a thorough exam, declining or stopping the procedure, or asking for explanation, and even just saying not today. And part of our role is to make it feel safe enough to do that. So to expand just briefly, in terms of controlling the pacing, if you are affected by FGMC, you might ask, or if anyone has undergone this procedure, can we pause? Can you go more slowly? Can you tell me before you touch me, to make the exam more of a conversation rather than just like a sequence of events? Your choice of positioning, so you could request maybe an alternative position, like lateral, rather than being in a lithotomy position. Just the draping for your comfort and dignity, so you can reclaim your own power in this position. Small physical adjustments can dramatically reduce vulnerability. In terms of control, so you want to control your exposure, so you ask to be uncovered only when necessary, stepwise exposure, not just full exposure up front. And I know that some of this might just sound like the bare minimum, but you would be surprised. And I just want to kind of let you know that it is okay to ask for these things to happen if they are not happening. You can also ask clinicians to not use certain words or tone, and request very clear non-technical explanations, because the words can either soften or sharpen the experience. And I don't know, sometimes when I listen to junior doctors speak to patients, I'm aware of how much jargon we use without even realizing it, and it is a foreign language. So if you don't understand something, it's happening to your body, you have the right to know. And that's part of informed consent. Another really important facet of trauma-informed care is agreeing on a stop signal before you engage in the exam. So a hand raise, a verbal cue. This can be really powerful. And pre-procedure planning. So that I know that this is usually part of what would happen within an FGM clinic, but just having that first or second, or however many visits it takes, just to build rapport, to talk through the exam and request written information, and just stop it from feeling like an ambush, and to eliminate that surprise element. And we've had talks on this before within the Tiger Network, but advocating for appropriate analgesia, pain management. So topical anesthetics, smaller instruments, staged exams, any alternative. So you should anticipate that things might be painful rather than just trying to react to it in the mid procedure. And then continuity of care is really important. So you could ask to see the same clinician wherever possible to build that trust and rapport, because that will only enhance your therapeutic relationship. Culturally sensitive care is super important. Making sure that your care is culturally safe and in your own language and in your own dialect when you request an interpreter. Sometimes it's not enough to request an Arabic interpreter because there can be nuances to it. So if you request one, whether it be in person or over the phone, make sure that it is the right dialect so nothing's lost in translation. And your documentation. So you can ask how things are documented. You can request certain wording because that medical record does travel between agencies. So you always have the right to say, how are you writing this down? And as I've said, the right to defer. So you don't have to do it. You can ask, what happens if I don't do this today? It's not a punitive thing. There shouldn't be any penalty to it. And then advocating through others, so bringing a trusted or support person, asking for a chaperone, just so that you feel safe. That is usually part of our normal operating procedure, but just to know that that is something that we can do. And asking for a referral, which we will talk about a little bit later on, but requesting specialist FGMC services or clinicians with experience. And I know that is hard because they're not everywhere, but you can always ask and know your options for trauma-informed and culturally sensitive care, because not all care is equal, and that's okay to acknowledge. That's my little tangent about patient empowerment. In terms of, so the non-FGMC specialist healthcare providers do have a really important role, and I like to see it as you kind of create the rapport that you can then transfer onwards to the specialist providers. So making sure that you're approaching any discussion with sensitivity and respect. Know yourself. Like, some of the things that you might be hearing could be really foreign and really shocking to you, and you might have a normal response to be shocked, and that might be in your face. You might not agree with this at all. Some of the things might make you horrified. You can acknowledge that that is the case, and just kind of be real with it, but making sure that you remain respectful, even if this is something that you don't agree with, and I'm sure none of us do, but this is something that has happened to these women. They're here for your help, for your care, and they deserve a non-judgmental perspective. Just remember, I'll take the opportunity to say that FGMC isn't actually done to hurt people. It is a procedure that is done out of love and out of, parents wanting the best for their children. And so they're not doing this because they don't love their children. So just be mindful that, the strengths of culture, it can be very, very strong. And when you're not in that context, when you haven't grown up with it, it can be hard to understand its strengths. So offering that holistic care, so not just physical wounds, but emotional and psychological ones, making sure that you're providing access to services like therapy, counseling, medical interventions that are all aimed at improving function and well-being. Making sure that you're educating patients on reconstructive options, pain management strategies, pelvic physios, pelvic physios, and coaching and intimacy sexual health physicians. They can all help women build confidence in their own bodies. So you want to foster a positive sense of self. So in terms of empowering the clinician, this is where really small actions can have huge effects and where you can truly transform your care. So before the exam, these are kind of similar to what we've said before. Ask the permission to discuss FGMC sensitively, using clear, non-judgmental language, using the terminology that the patient wishes you to use in their own language that they're comfortable in having this conversation. Explain why the exam is needed. This is all part of informed consent, and using visual aids like models or diagrams, and sometimes even women would be happy to use a mirror. Those can always help too. So during the exam, you want to offer choice and control continuously. Use the smallest size speculum, defer if you need to, consider alternative approaches, making sure you're respecting their dignity, their comfort. So constantly reassessing and checking in with the woman. And then after, obviously, once they're clothed and not in a vulnerable position that you're going to kind of be standing over them, talking about it, just debrief, tell them what you found, what you think, validate their experience, and offer follow-up or specialist referral. So the WHO emphasizes the importance of communication, informed consent, and respectful care as core of management. In some cases, though, these standard approaches, they don't work. And like I've said, the type 3 FGMC might require defibrillation, even to allow the examination or procedures. This pain may require procedural modification or specialist referral. And just to hammer home the fact that these aren't like difficult patients, they're just different anatomies that require a different care pathway. And you'll need to refer these ladies to a gynecologist. And so, like I've said, you want to provide first-line support, basic counselling, information reassurance. And I'll send through in the chat some of the NHS resources and fact sheets for FGMC. So refer when necessary. So as part of the WHO care of women and children living with FGMC, type 3 FGMC needs a gynecologist referral. Any woman that has mental health issues stemming from their trauma needs psychological counselling. And, things like I've said, pelvic physio, sexual health physicians or clinicians, these are all people that you want to refer to as required for their care, particularly if the woman is planning on having a child and they've had type 3 FGMC, they're going to need to have a defibrillation process before they give birth. And so in order to build the rapport and the trust and things, you want to try and do that as early as possible. And then importantly is promoting awareness. So advocating for improved training resources, knowing your network, creating awareness. That's all part of getting best practice for these ladies. So the evidence, essentially, there's a lot of people around the world doing really amazing things in this field in terms of evidence, but I guess due to the nature of the beast, it is somewhat limited. A lot of the evidence that we rely on might be observational, heterogeneous, not always controlling for confounders. We have limited data on best approaches to exams, limited patient-reported outcomes, and gaps in trauma-informed procedural research. So we're often operating in that gap between evidence and empathy. But it just means that, there's limitless possibilities for us if we want to do research and if we want to make things better for women. If you've got a topic of interest that you want to explore, I'm sure it hasn't been done before, so you should go for it. So to close, I just want to return to where we started. So FGMC is often taught as anatomy, classification, clinical implications. But for patients, it's rarely just that. It can carry layers of culture, identity, pain, silence, and sometimes trauma. And when someone presents for care, especially gynecological care, where it's inherently a vulnerable thing, they're not just bringing a clinical problem, they're bringing all of that with them. The way we respond in these moments matter. A rushed interaction can reinforce fear. A thoughtful one can begin to rebuild trust. And often it's not just dramatic gestures that make the difference. It's the small things like explaining, pausing, offering control, and listening. So I'll leave you with this. The next time you're in that moment, whether you're as a patient or a clinician, what is one small thing you will do to make that experience safer? Because that's where change begins. Thank you.